Hi, thanks for coming. I'm Jamie Speer from CT Fertility, and I'm happy that you're here. I'm happy to answer any questions you have about our clinic and our programs. Just to give you a little background, our medical director is Dr. Michael Doyle, and we've been in practice for over 20 years, and we have helped over 5,000 babies be born. Many of those babies to gay couples and singles all around the country and all around the world. We have a large international client base. And so we serve as a medical clinic. We have a large in-house egg donor program that you can select from. We have photos of the donors, childhood photos and adult photos, and you can let us know some of your preferences, and our matching coordinator can do her best to help you find the donor that's a good fit for you. We have a lot of situations at our clinic where couples and singles meet their egg donor, so it doesn't have to be anonymous all the time. If you prefer it to be anonymous, that's fine. But we do have a lot of situations where people do have some contact with the donor, either in person or by Skype or by telephone. Most of the donors are very flexible, and really just say it's up to you as the parent if it's important for you to have a meeting, and most of the donors are very flexible with that. So that's something that a lot of the clients we've worked with have really enjoyed, just having the opportunity to meet the donor, and they can sort of take that experience into the future and speak to their children about the meeting that they've had with the donor at some future date. A benefit of having donors in our own program is that we know them really well. They're also very local to our clinic, so as opposed to some donor agencies where you might need to spend a lot on travel costs, that doesn't really happen at our clinic since the donors are all local, and all their screening and monitoring is happening right with us. We do a fertility evaluation of all the donors, measuring their hormone levels and counting their follicles before they would even be approved into the program, so that we really have a good sense that they're likely to produce a large number of eggs. We do a lot of genetic testing and family history analysis. I work as a genetic counselor for the practice, so I spend a long time talking to the donors about their family history, and if they have any genetic testing results, going over those with the donor as well as the parents. So when people pick a donor, we would usually have a session where we talk to the intended dads and go over the donor's history and what genetic tests have been done. We would go over the dad's history and offer genetic testing to him as well. Sometimes a donor might be a carrier for some rare condition, and a dad might want to be tested for that same condition to make sure that he wouldn't have a pregnancy that would be at high risk for that condition. Of course, if a donor is a carrier for a very common, serious condition, she's probably just not accepted into the pool, so that would be unlikely to really pose a big problem for you as a dad. But we do a lot of testing, so sometimes a very rare thing pops up that you might want some additional reassurance about. At our clinic, we really like to have a lot of options to offer you, so we have a lot of different programs, and in each of them we can promise you a certain number of eggs based on what the need is of your family building. So you might just need a few eggs, 5. You might do a full cycle, getting 15 to 20 eggs, or you might decide to do something like a shared cycle where you just get 10 eggs. If you're a single sperm source, like a single dad or a 2-dad couple where only one of you is going to be the sperm source, then a shared cycle can be a good idea because you may not need more than 10 eggs to work with, and you can cut down some of the costs that a full cycle might have. If you are a 2-dad couple and would both like to be genetic dads, then usually we'd recommend a full cycle, getting 15 to 20 eggs, because if we're splitting the number of eggs with 2 dads, we really want to have the best opportunity we can to have really good quality embryos from both of you that we can think about transferring. We do offer a plan where you can do a single cycle and everything is included, the donor's medications and her testing and the screening of your surrogate and her medications and the embryo transfer and the sperm testing and all of the related expenses and the IVF charges and everything included as a single cycle package. And if your single transfer doesn't work and you have frozen embryo transfers to think about after your first fresh, then we have a progressive discount plan which gets increasingly more affordable. So your prices are reducing if you do need to have several attempts. So some people find that really reassuring. Other people will elect to do an unlimited plan where for one fee it will cover all of your IVF charges and transfers. Even if it takes you 5, 6, 7 transfers to get pregnant, it would all be under one program. So some people go back and forth between the single cycle plan and the unlimited plan. Some people do select the single cycle plan, and that's because pregnancy rates are very, very high. If we transfer 2 high quality embryos from an egg donor to a surrogate, we're seeing about an 80% pregnancy rate. So some people feel if the pregnancy rate is that high, maybe I don't really need to sign on with an unlimited plan because I'm probably not going to need 5 or 6 or 7 transfers to get pregnant. But that's an individual decision, and of course we would help you iron out what are some of your issues and concerns and then help you come to a plan that feels right for you. Do you have a question?
Right. In relation to that 80% with the double embryo implantation, does that mean that 20% of those are resulting in a single fetus?
No. 80% means that if you transfer 2 embryos, 80% of the time there's a pregnancy, that's 1 or 2. 20% of the time the pregnancy test is negative. 20% it doesn't work. 80% it works. Now of that 80%,
right, that's the part of
yeah, it's about 50% of that, maybe a little bit higher, 50 to 55% of that would be resulting in a twin pregnancy, and about 45-50 of that would be a singleton. So if we split out the 100%, 20% is you don't get pregnant at all, about 40, maybe a little higher than 40% is you have a twin pregnancy, and maybe 40, a little less than 40, you have a singleton pregnancy, right? Because the 1 and 2 add up to the 80%, and then 20% isn't successful. Obviously, when it's not successful, most of the time in our cycles, we have really good quality frozen embryo transfers that you can attempt if that doesn't work. Does that answer
yes.
that? Okay. Another option we offer is the possibility of freezing some of your donor's eggs without fertilizing them. This has been requested by some 2 dad couples who maybe one of them, it's more important to him to be the genetic dad than the partner, and they might say, just myself or my partner wants to be a genetic dad, and I don't think that's so important to me, but I'm not sure what will happen in a couple of years. Maybe I will have a baby, and then maybe my partner will want to be a genetic dad in a couple of years, but we may not do that. So we're not quite sure what our future plans would be. So some people might think about doing a full cycle and maybe getting 20 eggs and fertilizing 12 of them with one dad, and maybe just saving 8 of them, as an example, as eggs, and just saving them and freezing them. And then if the partner in the future wants to come back and try to have a sibling, then you have those 8 frozen eggs that you can work with. And then if you decide that your family is complete and you really don't want to use those 8 frozen eggs, you can sort of give them back to the clinic for our frozen egg bank, and you'll get a refund for that. So The issue is if you have eggs available, they're obviously not attached to you yet. You're not genetically connected to them. So some people would find it easier to release them as eggs rather than as embryos. Obviously, it's an individual decision, but that's something that some people would think about.
And when you release them, they go to be donated to somebody that needs a baby?
Right, the eggs or the embryos?
The embryos.
The embryos. So if you have, let's say you have 6 very good quality embryos and you transfer 2 and you have twins and then you're totally done with your family and you have 4 embryos left, you can have a few different options as to what to do with them. So you can store them yearly for a while until you really make a firm decision about what you want to do. You can discard them if you know that you are done building your family. You can donate them for some science research. And in our clinic, we actually also have an embryo donation program. So the embryos could be donated to other people with fertility issues or other people who want to have a baby who maybe don't have the resources to do a full cycle themselves. So obviously, some people are comfortable donating their embryos to that program and some people are not. We're not saying you must do that, but that's an option for people who like the idea of giving the embryos a chance and like the idea of helping a family, bless you, helping a family have a baby who wants to. Bless you. We also do some testing of embryos at our clinic. We can biopsy embryos and test them for chromosome problems, which also gives gender information, so some people ask about that. We can remove 1 cell or sometimes a few cells from an embryo at either day 3 or day 5 of development and test to see if chromosome problems are there, and then decide which embryos to transfer based on those results. In egg donor cycles, that doesn't always happen all of the time because the biggest risk factor to have an embryo with a chromosome problem is how old the egg donor is. Chromosome problems increase in frequency as the mother is getting older. They don't really increase in frequency as the dads are getting older. So since you're going to be using an egg donor who's very young, in her 20s, almost all the time, then a lot of people think the risk for a chromosome problem is not really high enough to warrant putting the embryos through that testing process, because embryos are very flexible, which is very good, but there is a chance that that biopsy process on the embryos could affect them and possibly lead to a reduced chance to implant successfully in the uterus of the surrogate. So doing testing on embryos is a possibility and it's something to think about, but it's not routinely done and not incredibly commonly done in egg donor cycles. So we have a lot of different options and we're happy to talk to anyone about them. With respect to surrogacy, we work with all the top surrogacy agencies. We sometimes have surrogates who apply directly to our clinic for approval, and our medical director, Dr. Doyle, reviews their records and may approve them to be surrogates. So we occasionally match clients with surrogates directly through our clinic, but most commonly we still are partnering with a surrogacy agency to help the couple or single person find the surrogate, and then once the surrogate is found, we take over and do all the medical screening and coordination of the cycle and the embryo transfer. Okay. I have Debbie here with me, who's the finance director for our clinic, so any questions related to that, she's of course happy to help you with. And if I can answer any questions about our clinic or our options, I'm happy to do that.
Just curious, as far as numbers go, how many couples versus singles a year come to you? Go through the process.
Well, I mean, we did over 300 cycles last year. That's a mix. We certainly have a large proportion of them are male couples. And again, they're from all over the United States as well as all over the country. We do a lot of international patients, France, Sweden, Spain, a lot of international cycles, plus, of course, local people. I'd say the majority of our egg donor surrogacy cycles are with gay male couples or gay single dads. So it's a large proportion of our client base.
And of that base, you say it's mostly couples?
Yeah. More couples than singles, yes, definitely. But we certainly work with single males. I happen to be a single father myself, so hopefully I would be willing to work with them. So yeah, overall numbers are more commonly it would be couples, but that certainly doesn't mean we won't work with singles. We definitely do. We have many single males in the process with us right now.
I just ask out of curiosity, would it be like 1 out of every 3? 1 out of 3
Would be single? No, it's probably a little less than that. I mean, 1 out of 7 or 8, maybe. So,
This helps to know how alone I am in the world and pursuing this.
Yeah, you're not alone. Though.
No, of course not.
You're not alone.
Yes.
Most are couples, but we certainly have singles. Certainly do. Can I answer any other questions?
The gender, is there a way to actually, other way to have preference in gender? Like I know that there's a methods to actually separate the sperm, like into male and female. Do you use any of that?
So as far as gender selection, the most definitive way to do that would be to test an early embryo. So like I said, on day 3 or day 5, on day 3, when an embryo has about 8 cells in it, you can remove one of the 8 cells and then do some chromosome testing on it. And if you see 2 signals for the X chromosome, then you know that embryo is a female. And if you see 1 X and 1 Y, then you know that it's a male. So that's a very definitive way to check for gender. What you're referring to is more of trying to improve the odds. It's not really a definitive way to do it. The X chromosome is a lot bigger than the Y chromosome, and so you can try to separate the sperm. If you spin them rapidly, the sperm that have Y chromosomes in them go to the bottom quicker because they're lighter, and so that's a way of spinning out the X and the Y. And so you separate out the sperm. You have 2 layers of sperm, one that would be concentrated in females and one concentrated in males. The problem though is it's never going to be a definitive thing. Just if you take one from that layer that has mostly females in it, you can still have a boy from that layer and vice versa. So it's not a definitive way to do it. I think accuracy are sometimes in the 70-80+%, but remember it's 50% if you do nothing. So some people don't really think that's worth doing, and it's actually almost as expensive to go through that whole process as it is to do a definitive test on the embryo.
It destroys the cells in the embryo, right? Doesn't it damage?
Most embryos are very flexible and are not destroyed by the PGD process. It is a potential that an embryo might not continue dividing after the PGD biopsy or the removal of the cell. Usually that risk is quite low though, probably not more than a couple percent. So again, it's not something that's done in every single cycle with an egg donor, but it's something that some people ask about. Yeah. I know with our gay single dads and gay couples, I know some of them think that as men, they might have a harder time raising a girl. So for some people, they think about that as some people just have a preference, but some people say that it might be more challenging to raise a girl as a single dad compared to raising a boy. But that, that's an individual thing.
It's too much work for girls.
Well, I have girls and boys, so you can do it.
Do you have any, out of your head, percentage of gay couples that choose boys between boys and girls?
Well, most of the gay couples don't do the testing,
Okay.
right? So first of all, they probably wouldn't do it because the risk for a chromosome problem with a young egg donor is pretty small. And then I would probably say that of the gay singles and couples who do pre-implantation testing, who do gender selection, most of them want boys.
And what is the rate of success in terms of accomplishing the boy thing?
The boy thing, well, that's highly accurate because if you see a signal for the Y chromosome in the embryo testing, that has to be a boy. So again, there's a chance that your embryo might have a little bit of a lower chance to implant successfully, but based on having had that test done. But if you do get pregnant, it's high 90s that it would be a boy because it'd be very unlikely that that wouldn't be accurate. Other questions I can help you with?
If somebody want a boy, they have to ask for a separate chronology. First, male and female, or they wait until they check the embryo eggs.
I'm sorry, if someone wants a boy, how would they do it?
How they do it? They have to ask for a separate X and Y before the embryo or after when putting together in the embryo. They check the embryo.
Okay. So to have a definitive test, that's on an embryo. So that would be your egg donor has her retrieval, we get her eggs, we get your sperm sample, we fertilize the eggs, and then we grow them out. On the third day, day 3, that's when they have about 8 cells, you can remove 1 cell. So that's an early embryo. It's not before, it's an embryo. So you would test them as an embryo.
You test the embryo.
Yeah, you have to have a definitive answer on that, you have to test the embryo. If you do a test like that on day 3, we can get the results really quickly, in about a day and a half later, because the transfer of the embryo to the surrogate is usually done on day 5. So that testing has to be done very quickly so that you can get
So we know exactly is this male or female.
Yes, yes. There's also an option to do testing on day 5, and sometimes you have to take some cells from the embryo and freeze the embryo because you may not get results in time to do a transfer, because day 6 is really the last day. You have to do something with your embryos by day 6. You either have to transfer them to a surrogate or freeze them, but you can't continue to have them out growing. You have to do something with them.
What happened if the day 7 or 8 later?
After day 6, it's too late. Day 6 is really the last day that you can have them out of either being frozen or in a uterus. So day 6 is the end. So if you have a day 6 embryo and you're waiting for results on something, you can't wait another day. You have to either transfer that embryo on day 6 or you have to freeze it. Yeah.
One question. Do you know anything financial source company they can have for financial loan?
Yes, so there's some programs for financing assistance with fertility treatments, and so we have affiliations with a couple of them. One is CapEx MD, and they offer basically loans for fertility treatments, and another one is Springstone, which also offers different loans for different medical treatments. And sometimes people borrow as much as $40,000 or something on one of those plans and then pay that back gradually. So we're involved in both of those programs. We can send you more information on them if you'd like.
On the email.
Another question?
Just more questions regarding that. So if I test, like I would prefer to test on day 5, so because damage is the embryo will less, right?
Mm-hmm.
So, and then, like if you take biopsy for one embryo, right, and you freeze them all, right? So what if that turn out to be female, right, which I don't want right now? Then do you have to unfreeze the other one, test it, and how does it?
Oh, okay. So what you would probably do, so that you can test embryos on day 5, as I said, you would test all that you have that have made it to the right developmental stage. It's the blastocyst stage on day 5. And so there might be a way to rush that analysis so that you get the results back by day 6, the next day. And if you have the results back then, you can transfer the embryos to the surrogate. If your embryos are not of the right developmental stage and they can't be biopsied until day 6, then usually you're going to have to freeze them and then get the results and then decide which. So normally if say you had 10 embryos, you would test all 10 of them, and then you might get the results the next day and you'd say, okay, embryo number 1, 3, 5, and 7 are males and the others are females, and this one had a chromosome problem but all these others look normal, so these are the ones that we might pick to transfer to the surrogate. So you wouldn't normally test one, you would test all that you have usually.
Once they freeze, then, go through the process of, solving or whatever. I mean, how long does it take?
Once you have embryos and they're frozen.
I mean, let's say you get to day 5 or 6, and then you have to froze them. How long you have to wait?
Okay.
For them to do the process
Well, once you have them frozen, you can really thaw them and transfer them at any time. The issue would just be that if you have embryos frozen, you then have to have a surrogate, and she would have to be medically screened, and then she would go through her medication protocol, which would help develop the lining of her uterus, so it would support carrying a pregnancy. So that would take some time, several weeks for the surrogate to get ready to have a transfer. But the embryos don't have to be frozen. I mean, they might end up being frozen for 2 weeks or 2 months or 2 years. That part really doesn't make any difference.
But I mean, you have to be ready if you were planning to do it in 5 days.
Yes. So.
If not, then you have to wait until the next cycle.
Right. So timing-wise, that is something that could come up. So say you did embryo testing on day 5, and or you were looking at your embryos on day 5, and they hadn't quite reached the blastocyst stage. Maybe they would reach that late in the day, or maybe the next day on day 6. If your surrogate was about ready to have her transfer right then, and you couldn't have your embryos tested until day 6, then she can't have her transfer. Because once it goes beyond that, then they would have to be frozen, and then the surrogate would have to stop her medications and get another period, and then start a whole new cycle of medications.
That would be an extra expense, for the health.
No, not really, because she wouldn't really have had the transfer. She would end up taking another set of medications.
Yeah, she'd go through the shots,
Right, she'd have to do her medications again.
monitoring probably.
Yeah, then she might have to be monitored
Monitored.
additionally. And then it would take, it would probably take another couple of months to have her ready to have a transfer again if something like that were to happen.
How long can embryos, sperm, and eggs be kept frozen before they go back, let's say?
At this point, indefinitely.
Really?
In the past, remember, things were frozen in a very slow, gradual method, and that ended up resulting in a lot of ice crystals accumulating on them, and then that impacted their survival rate. So eggs or embryos that were frozen 10 years ago, when you went to go thaw them, many of them wouldn't survive that process. They would try to thaw them and they wouldn't survive that. So about 6 years ago, we started using a vitrification method, which is a flash freezing method for eggs and embryos, and that doesn't result in those ice crystals. So the survival rate for eggs and embryos that have been vitrified is excellent, like high 90s. So it's very rare for an embryo or an egg not to survive being thawed. They almost all do at this point. Sperm can be frozen for quite a long time. In our clinic, our ideal is to use a fresh sperm sample. We certainly can use a frozen sample if that's, maybe someone lives far away and can't get here for the cycle, things like that. But for some men, the freezing and thawing of their sperm might result in almost half of them not making it, not surviving. If you have a very large or high sperm count, even if you lost half of your sperm, you'd probably still have quite a lot. So it probably wouldn't be a big problem. But if your sperm count was on the lower side, you might be a little concerned about the possibility of losing half of them. So just to optimize the chance of having a good number to work with, we generally prefer to use fresh sperm sample rather than a frozen one.
Is there any guidelines as far as how quickly a sperm count starts to diminish for older men?
No, when men are in their 30s, most commonly the sperm count is fine. There's no significant problems there. We do know that as men get older, some issues with sperm are seen more commonly. One of them is damaged DNA in the sperm. We know that we all have sperm cells that have some DNA damage. It's a normal thing. And there's a variety of things that affect the DNA and damage the DNA. So sometimes certain medications we have to take might damage the DNA of the sperm, or if we are exposed to a lot of heat or take a lot of hot baths or something, that can do it. Some medical conditions can affect the DNA of the sperm, and the aging process is something that also does that. So if we have men in their 50s, for example, which we have several at our clinic, we might encourage them to think about doing a special test to look at the DNA damage in the sperm. It's called the DNA fragmentation test.
How much is it?
How much does that cost? I think it's a few $100s. That's separate than a regular semen analysis, which would look at your count and your motility and your morphology and your antibodies, and that's sort of a regular semen test. This would be a more detailed one. But the good news about that is, interestingly, if you find that you have a DNA sample, a sperm sample that has a lot of DNA damage to it, there's some medications, there's some antioxidant vitamins that you can take for 2-3 months, and that might significantly improve the sperm quality.
Which
There's
It's going to start right now.
I happen to have no, I don't. So one we've been using is called Proxeed, Proxeed, Proxeed Plus, and it's an antioxidant therapy, and we have seen several men who initially took that fragmentation test and saw a high proportion of DNA damage take that vitamin for a few months, and and come back, and it's much, much better. And we,
And it was basically the vitamin, also that they were stop smoking or stop
good question. I
bicycling.
mean, smoking, alcohol, there's many things that can affect the DNA of the sperm. Age is just one of them. There's many, many things, but, so that's a good point. You know, they'd encourage people to eat a good diet, you know, have fruits and vegetables more often, you know, wear boxer shorts instead of briefs, and don't take a lot of hot baths, and, you know, don't smoke.
Sauna. Okay.
Yeah, I don't know, I would avoid it. If you're really trying to have your sperm quality be optimal, we'd encourage not. See, the heat is really damaging to the sperm, so the more that people have exposure to heat, the worse it is for the sperm. Even losing weight can actually improve the DNA quality, because sometimes if men are heavier, a lot of men tend to gain weight, you know, in their stomach area, and that can actually provide an increase in temperature for the testicles. So if men lose weight, they actually usually have better quality in their sperm. So again, there's a lot of different things that affect the sperm quality. But the good news is you can make some changes to improve some of those things. I mean, you can't really change your age, but you know, you can make some dietary changes. You can take some vitamins. You can try not to smoke if you're a smoker. You can, you know, there's things that you can do that will improve your sperm quality.
Is autism any higher in children conceived through IVF?
Autism is something that a lot of research has been done lately on, and specifically there's been some studies trying to look at, as men get older, when they're fathering children, is the chance for the children to have autism a bit higher.
Right, I've heard of that.
Yeah,
I'm
and
wondering
the answer
IVF
is the answer is a bit higher for older men. The likelihood of a baby having autism, also a couple other conditions like schizophrenia and bipolar disorder, are also thought to be mildly increased in men as they get older. Not especially dramatically. We should clarify. Really, most men who are in their 40s or 50s do have healthy babies. So it's just sort of a slight association. I don't think the risk for autism is generally thought to be significantly increased for IVF in general. But it's there's been an age-related risk for autism that we know more about.
I heard somebody they have STD, and then I heard that do they need that sperm to be washed out to avoid STD or something?
With an STD. Well, so when you do a surrogacy cycle, you do need to have some FDA screening. The Food and Drug Administration has requirements for screening, and that's largely looking at infectious diseases. So if someone has a panel and they're positive for something on that panel, you may need to be treated for something and then come back and see if that has improved. We actually work with men who are HIV positive because there are ways to wash the sperm and actually do very sensitive DNA testing of the sperm to make sure there's no HIV particles in the sperm. And then once we have a clean sample, we can use that sample to fertilize eggs and transfer embryos to a surrogate. So being HIV positive does not exclude you from this process. We've done it successfully many, many times.